Thank you all for joining us today for this targeted oncology virtual tumor board, which is focused on graft-versus-host disease. In today's presentation, my colleagues and I are going to review 3 clinical cases. We'll discuss our individual approaches to treatment of each patient, and we'll review some key clinical data that helped impact our decisions. I'm Dr. Corey Cutler from the Dana-Farber Cancer Institute and Harvard Medical School in Boston. Today, I'm joined by Dr. Dan Curiel from the University of Utah's Huntsman Cancer Institute and Dr. Usama Jergis from the Sidney Kimmel Cancer Center in Philadelphia, Pennsylvania. We'll start with a little bit of background on graft-versus-host disease. So as we all know, GvHD is one of the main causes of non-relapse mortality following allogeneic stem cell transplantation. And we have 2 main clinical syndromes that we deal with. Acute graft-versus-host disease is a syndrome that occurs relatively early after transplant, mainly affecting 3 organs and 3 organs only: the skin, the gastrointestinal tract, and the liver. It's caused predominantly by a T-cell mediated reaction. Chronic graft-versus-host disease, on the other hand, is a very heterogeneous syndrome that occurs months to even years following transplantation. It resembles a number of immunologic or autoimmune diseases and really is quite a unique syndrome in each individual patient in whom it's affecting. It really has long-term implications on quality of life for the patients that are affected. The risk factors for acute and chronic GvHD are actually quite similar, and acute GvHD was once thought to be the main risk factor for the occurrence of chronic graft-versus-host disease. About 25 to up to 50% of patients who get transplants from well-matched donors will have acute and or chronic graft-versus-host disease requiring systemic therapy. And a number of patients who require systemic therapy unfortunately have inadequate responses to corticosteroid, which is both associated with very poor prognoses and the requirements for a number of other immunotherapeutic targeted approaches. When we talk about graft-versus-host disease, almost all of our patients require some form of prevention for GvHD. Shown here on this slide are a number of molecular pathways and targets that we use to try to prevent graft-versus-host disease. It turns out that most of these pathways are also active when we are talking about treating acute graft-versus-host disease. What is the standard of care in North America is generally a combination approach for prevention of acute graft-versus-host disease. So in North America, most patients will receive a combination of a calcineurin inhibitor, either tacrolimus or less commonly cyclosporin, in combination with an anti-proliferative agent, most commonly represented by methotrexate and sometimes represented by mycophenolate mofetil. But there are a number of other different agents that are active, and some of them and some of their pathways are shown here. This slide really shows one of the seminal phases of acute GvHD pathways. This was devised by Drs. Anton and Ferrara well over 3 decades ago, and speaks to T-cell activation in the context of exogenous or even internal stimuli for upregulation of the immune response, involving upregulation of T-cell activity, cytokines that upregulate this entire pathway, finally leading to the elaboration of lipopolysaccharide and other types of inflammatory markers and immune attack on target tissues. And despite being over 30 years old, this is still a model that we actively use even in today's day and age. In terms of risk factors, far and away, the most important risk factors are HLA related. But some of the things that we can manipulate as stem cell transplant physicians are choosing donors that are younger, so trying to minimize older donors. We try to minimize sex mismatch when we choose our stem cell donors, and we can choose the preparative regimen intensity, understanding that regimens with higher intensity are associated with more graft versus host disease, and understanding that regimens that use high dose radiation are also associated with higher rates of graft versus host disease. This slide demonstrates the agents that we commonly use for prevention. As I mentioned before, the calcineurin inhibitors and methotrexate are used commonly at our institution and at several others. The mTOR inhibitor sirolimus is commonly used. There is an increasing use of the agent cyclophosphamide to prevent graft versus host disease. This has been pioneered by physicians at Hopkins in Baltimore and has predominantly been used in haploidentical transplantation, but more recently has started to be used in unrelated donor transplantation. And then, of course, at the end of this slide, clinical trial agents speaks to the fact that the real way that we are going to improve outcomes in transplantation is really with the use of large, well-designed and randomized clinical trials to test novel agents and novel strategies to prevent graft versus host disease. And there are a number of strategies that are being used. So in addition to the pharmacologic agents, we are now attempting to modulate stem cell grafts, either with depletion of all T cells or selective depletion of T cells. We're also doing graft modulation before the cells are infused. We're exploring a whole other category of drugs that modulate T cell trafficking, so preventing the T cells from getting to the target tissues. We're using T cell co-stimulation antagonists, so drugs that prevent the upregulation of T cell responses. And then there are several other classes of agents that are being used both in the treatment and for prophylaxis, such as the JAK inhibitors, for example, which we'll speak about a little bit later on over the course of this tumor board.